proximal is we use di diamox or acetazolamide,
Yes.
where carbonic anhydrase is inhibited. Then in PCT, sir, sodium potassium 2 chloride symporters can be blocked, sir, by furosemide, loop diuretics. And at DCT, sir,
Loop diuretics.
loop diuretics.
Huh.
At DCT, sir, sodium chloride is blocked by thiazide-like diuretics.
Thiazide diuretic. Thiazide like is which one?
Hydrochlorothiazide
Is thiazide
right.
diuretic? Thiazide like is metolazone.
metalazones.
Okay. Uh-huh.
And at collecting ducts, sir, we can use spironolactone.
Yes.
Or ENAC channels are also there where amiloride or trimethrin can be used.
Can be used. Okay. So there is one more diuretic which is not mentioned. Not used by us also, but can be used. Anyone?
Mannitol.
Mannitol. Okay. Used in neuro. Albumin plus diuretics. Chandrasekhar, have you used? Or any pediatric resident? Dr. Rahul, Major Gaurav. Sit down, Chandrasekhar.
So, albumin.
Do you use it?
Yes, sir.
Okay.
Then
now tell me, what is the mechanism? What is the logic behind using it? Albumin with diuretics.
So albumin increases the osmotic pressure, sir. So
increases the intravascular renal
volume.
perfusion is increased.
Then
anything else? Yes, you're right. So it increases the delivery of diuretics till tubules so that it reaches the tubule and acts on the channels through luminal side. Otherwise, if albumin is not there, it becomes tissue bound. It is not available. It does not reach kidney. Okay. So how much is used? Can you answer?
Sir, 0.5 to 1 gram per day over 0.5 to 1 gram per kg or 4 hours, sir. Albumin.
Okay. Oh, you can, yes. Bolus followed by diuretic, or you can use infusion over 24 hours, something like that. Sit down, sit down. What do you monitor during diuresis? Chandrasekhar, now you answer.
Sir, we monitor for blood pressure.
What are the side effects of diuretics?
Sir,
basically, we were using 4 diuretics.
Hypotension.
Yes.
And electrolyte imbalance, sir.
Which one?
Sir, hypokalemia, hyponatremia, sir. And
anything else? Hypo or hypercalcemia can also. Hypomagnesemia causing hypokalemia. What else?
And also blood sugar monitoring also, sir. It will lead to
which diuretic can cause?
Loop diuretics will cause hyperglycemia.
Sure. Anyone? Rajesh, you want to answer? Hyperglycemia किससे होता है? Thiazide, not loop diuretics. Okay. And ototoxicity is because of loop diuretics, not with minimal. When you push, so whenever you are giving large doses, do it over some period of time, maybe 30 minutes, 1 hour, not as a bolus. Sit down. What are the complications of nephrotic syndrome? Shweta?
So nephrotic syndrome can lead to hypoalbuminemia, which causes thromboembolism, and it can also lead to infections. It can lead to AKI and CKD. It can also lead to nutritional deficiencies with copper and zinc.
Dyslipidemia.
Dyslipidemia. Bone diseases also.
And micronutrient deficiency. What is, sit down, sit down. Next to you. Satish, what is the mechanism of dyslipidemia?
Impaired hepatic metabolism and
why impaired?
Decreased oncotic pressure.
So yes, so liver synthesizes all the proteins. So it senses that proteins are low. So it goes into overdrive and starts producing more and more protein. That includes lipoprotein also. And it produces bad lipoproteins, LDL and triglyceride. And what else? Why HDL is low? Why? Anyone? Akash?
HDL is low because it is lost in urine, sir.
Yes. And there is also which enzyme deficiency? Ram?
Sir, lecithin transfer.
LCAT deficiency. LCAT enzyme. Okay. Now you answer. What is the mechanism?
Sir, coagulation abnormalities occur in urine because there is loss of both procoagulant and anticoagulant
Keep it
factors.
so that everyone can.
Both procoagulant and anticoagulant factors are lost in urine. In response, the hepatic regeneration of the factors increase. However, the balance tips off towards the procoagulant.
Procoagulant. So both are lost, but it is more of procoagulant state. Which infection? Sit down. Kiran, Imre. Infections. She has history of multiple URTI or diarrhea in past whenever she. So which is the commonest infection?
Post-streptococcal.
Capsulated. Yes. Which organs?
Like Haemophilus influenza, Streptococcus
No,
pneumoniae,
these are the organism. Okay. Which infections are commoner?
UTIs.
Robin?
Sir, UTIs, pneumonia, sir, skin infections.
Peritonitis. So it was the infections were the leading cause because before treatment became available in 60s. Okay, what is the mechanism? Again, loss of protein. Immunoglobulins are lost. Alternate pathway components are lost. Sit down.
She underwent renal biopsy on 16th Jan 2025.
Okay. Any second year? Anyone? Francis, what are the indications of biopsy? Was it justified? She had some previous report mentioned in documents MCD.
Sir,
Now is it justified?
sir, in case of pediatrics and adult age, sir, can be unexplained CKD can the indication, sir. And in this case, sir, can be a repeat biopsy can prove since the medication is not efficient, it's not managed with the management of steroids, sir. So indication repeat biopsy can elicit
Sit
some
down.
other.
Rajesh, you answer. Third year.
Sir, any nephrotic range proteinuria in an adult is an indication for biopsy.
Yes. In children, no.
In children, no, sir,
No.
because it's mostly
Take
MCD. Then any unexplained AKI for more than 21 days, and proteinuria of 24-hour protein of more than 1 gram per day. Any steroid-resistant nephrotic
1 gram
syndrome.
with some sediments. Okay. Okay.
Uh,
And now it has come down to 500. Recent guidelines. I see. Okay. Continue. Good.
Then any unexplained any systemic involvement can again be an indication of biopsy.
Lupus, when we are suspecting, it becomes 500
Sir,
or at
500.
lower also we do. Okay, if it is active sediments are there, RBC cause. So nephritic you have to do, even if other than clear-cut case of post-streptococcal. Okay, so these are the syndromes: nephrotic, nephritic, AKI more than 21 days, CKD unexplained. At least 4 syndromes you should mention. What are the indications and contraindications? Next, Hemant.
Sir, contraindications could be, sir, any solitary kidney, sir, any shrunken kidney, or any ongoing infections.
These are relative. These are
Yes.
solitary is relative.
Sir,
Absolute.
any polycystic kidney disease or multiple cysts.
Yes.
Any infections, sir, pyelonephritis.
Yes. Local infection, not systemic.
Sir, and patient having coagulopathy or ongoing uremia, uncontrolled hypertension.
Uncontrolled hypertension. That is what we see in ward. What else? Thrombocytopenia. So these are the factors. Any renal neoplasm we don't do. It may be vascular and may bleed. Shrunken kidneys, what? 9 to 12 is normal size. But if it is around 8, we still go ahead. Helps.
Now I would like to call my pathology colleague to discuss the biopsy findings.
Good morning, everyone. We received a renal biopsy on January 16th of 2025. The renal biopsy on scanner view showed a single core, which predominantly showed renal cortex with 16 glomeruli, and none of them were globally sclerosed. So before moving on to the index case, we should know that the renal biopsy is approached in 3 compartments. The first being glomerular compartment, the second being tubulointerstitial compartment, and the third being the vascular compartment. Here we can see 3 glomeruli, out of which 2 of these show normal histomorphology, and the one in between shows segmental sclerosis.
What is segmental, Shishi? Tell us.
So segmental is when one glomerulus, in one glomerulus, there is less than 50% of sclerosis.
Can you show to the?
This is your, this is the whole
If it is more
glomeruli.
than 50%, it is the
Glomerulus.
global.
Yes, sir. On further magnification, on the left, we can see that this glomerulus shows normal histomorphology with patent capillary lumen. And here on the right, we can see that this glomerulus shows segmental sclerosis.
Okay, some part. Less than 50%.
Less than 50%.
Yes. Good. Continue.
Here in this glomerular compartment, this is the hilar region, and in the perihilar region, we can see the segmental sclerosis. So it is called perihilar sclerosis. And in the uninvolved tuft, it shows segmental mesangial hypercellularity. We also did Jones methenamine silver stain, which highlights basement membrane and mesangial matrix to see for interstitial fibrosis and tubular atrophy. So here in the tubulointerstitial compartment, we can see that there's no interstitial fibrosis or tubular atrophy. But in the vascular compartment, hyperplastic arteriole is noted. And in this glomerulus, segmental sclerosis is noted as well. On further higher magnification, this hyperplastic arteriole shows a characteristic onion skinning appearance. We also did Mason's trichome stain to see for fibrosis and hyaline arteriosclerosis. While there was no fibrosis identified, few arterioles showed hyaline arteriosclerosis, where the hyaline material was stained red. Direct immunofluorescence was performed, and it was negative for all immunoglobulins and complement, as we can see here. On electron microscopy, on right is our index case, and on left, we can see a normal capillary loop with with normal foot processes, which show penetration into the basement membrane at regular interval. Here in our index case, we can see that there's a diffuse foot process effacement, which was more than 80%. Salient features on microscopy in the glomerular compartment. Out of the 16 glomeruli, 3 glomeruli showed segmental sclerosis. 1 was in perihilar region and 2 NOS. So as per Columbia classification of FSGS, it fit in FSGS NOS. And it was not a hilar variant because more than 50% of perihilar segmental lesions are required for it. So the other variant for FSGS are collapsing variant, tip variant, and cellular variant. Coming to the tubulointerstitial compartment, we did not, no significant tubular atrophy or interstitial fibrosis was noted. In the vascular compartment, hyperplastic and hyaline arteriosclerosis was seen. And on electron microscopy, diffuse foot process effacement was noted. So the final opinion was focal segmental glomerulosclerosis, NOS.
Go back to the previous slide. Previous. So out of 16 glomeruli, what is the minimum number you require? You expect?
So 1.
1.
For FS.
For any biopsy or any specific? Any. It's okay. It's okay. And what is IFTA? IFTA is less than 5%.
Yes, sir.
What is the normal IFTA percentage?
So there's grading in IFTA, and it's like less
When
than
does
25%.
it become significant? When do you say it is chronicity?
So more than 25%.
Okay. Thank you.
Thank you, sir.
Start.
With this, the final diagnosis of focal segmental glomerulosclerosis infrequent relapser was made.
Now, continue.
She was managed with salt restriction, high protein diet, albumin and loop diuretic infusion, prophylactic anticoagulation, oral steroids, other classes of diuretics, and calcium and vitamin D3 supplementation.
So management of